It is my pleasure. My pleasure to introduce to you today Dr. Rob Colbert. He's one of the third-year senior fellows here at the University of Washington. And it's been a pleasure to have him in clinic with me this past year. He's been a great addition to our HCM program. His background, he's went to undergrad at the University of Wisconsin, migrated over west just a little bit to go to the University of Minnesota for medical school. Got a little son when he went down to Vanderbilt, and then finally came to his senses and came out west here at the University of Washington for his fellowship program. It's been great having him the last several years. He's going to go back to Minneapolis, take a job in St. Paul, actually with one of our former cardiology fellows out here, Chris Thomas, as well. So it's my great pleasure to introduce Rob today, and he's going to be talking on cardiac myosin inhibitors and hypertrophic cardiomyopathy. Therapy of the near future. Okay, take it away, Rob.
All right, thank you so much, Dr. Owens, for that wonderful introduction. And I should say that actually I'm from Minnesota originally, so I migrated east to the University of Wisconsin, but my loyalties lie in Minnesota. But today we are going to talk about a new class of medications becoming available soon for the treatment of hypertrophic cardiomyopathy called the cardiac myosin inhibitors. I have nothing to disclose in this presentation. Here is a short outline of what we will cover today. First, I will give a brief introduction to hypertrophic cardiomyopathy. We will talk about the current guideline management for patients with HCM. Then I will delve into the presumed mechanism of action for cardiac myosin inhibitors based on early studies performed in animals. And finally, we will take a deep dive into the first randomized clinical trial, as well as some other smaller trials for mavacamten, which will be the first cardiac myosin inhibitor available for prescription. Hypertrophic cardiomyopathy is characterized by an unexplained pathologic thickening of the left ventricle. The thickening is often in an asymmetric distribution, most commonly involving the septum, but can sometimes involve the apex and or the lateral wall. Left ventricular outflow tract obstruction may or may not be present depending on the thickness of the septum and the presence of systolic anterior motion of the mitral valve. On pathologic specimens, one can see varying degrees of myocyte hypertrophy, myocyte disarray, and interstitial fibrosis seen here in this pathology slide. The classic findings can really develop at any age, but most commonly begin to develop during puberty. Once considered a rare inherited cardiac disease, HCM is now recognized as much more common with worldwide distribution. Estimates within the general population put the prevalence at about 1 in 200 to 1 in 500 people. This would mean that anywhere from 15,000 to 38,000 people may be affected in the state of Washington. HCM is most commonly a single gene disorder with an autosomal dominant pattern of inheritance, whereby a single mutation is usually sufficient to cause the disease, although with variable penetrance and expression. The mutations typically affect domains in genes that code for sarcomere and sarcomere-associated proteins, leading to the thickened heart muscle. This is a schematic structure of a sarcomere composed of the thick and thin filaments here, and then the proteins that are associated with HCM. The established causal genes and their population frequencies are listed here. Approximately 60% of patients with HCM have a clearly recognizable familial form of the disease. The clinical manifestations can be grouped into the 4 most common. As a consequence of the thick myocardium, the left ventricular end diastolic pressure is elevated, which in turn raises left atrial, pulmonary venous, and pulmonary capillary pressures. The LV diastolic pressure increases markedly on exertion, causing classic symptoms of heart failure with exertional dyspnea, exercise intolerance, orthopnea, and peripheral edema. A little over 1/3 of patients with HCM have LVOT obstruction at rest, which is intensified with exercise. 1/3 have provocable obstruction with Valsalva or exertion. and the remaining third have left ventricular hypertrophy without obstruction. Patients with severe obstruction usually have elevated ventricular diastolic pressure and exertional dyspnea, which may progress to frank heart failure. Exertional or immediately post-exertional syncope may be caused by severe obstruction. Patients with HCM often experience ischemic chest pain, which may or may not have the typical features of stable angina. This symptom occurs because of an imbalance between the myocardial oxygen supply and demand. There is myocardial hyperperfusion due to reduced blood flow through the thick-walled intramural coronary arteries, leading to luminal narrowing, and the ischemia is also due to increased oxygen demand of the hypertrophied myocardium. Patients can present with palpitations, presyncope, and syncope, often caused by recurrent non-sustained ventricular tachycardia. NSVT is detected in 20 to 30% of patients and is a major risk factor for sudden cardiac death, as such episodes may degenerate into ventricular fibrillation. Atrial fibrillation occurs in about a quarter of patients with HCM and LVOT obstruction. AFib is poorly tolerated because the combination of the loss of the atrial contribution to ventricular filling and the rapid heart rate that shortens diastolic filling time. AFib is also a major risk factor for thromboembolic stroke, regardless of the CHADS-VASc score. So many patients with HCM and AFib are put on anticoagulation. I should say guideline recommendation, all patients should be. Cardiac imaging is the key to clinical diagnosis. An echocardiogram can show evidence of septal hypertrophy, and Doppler measurements can tell us if obstruction is present or not. This is an example of hypertrophy without obstruction, with an LVOT velocity here of around 1.6 meters per second, while this is an example of significant obstruction with an elevated LVOT velocity of nearly 5 meters per second, translating to an LVOT gradient of 100 millimeters of mercury. An outflow gradient greater than 30 millimeters of mercury is considered pathologically elevated. The obstruction that develops is due to hypercontractility of the myocardium, with systolic anterior motion of the mitral valve also playing a role in some patients, as you can see here in this image. The systolic anterior motion can be associated with varying degrees of mitral regurgitation, as you can see on these color Doppler images here, with this patient having severe mitral regurgitation. LVOT obstruction provides important prognostic information, including prediction of future heart failure progression. Patients with provocable gradients more than 30 millimeters of mercury progress from New York Heart Association functional class 1 or 2 up to class 3 or 4 at a rate of about 3% per year. And those with resting obstruction progress at a rate of about 7% per year. The percent survival of patients with non-obstructive disease is seen here in yellow, and the patients with obstructive disease is seen here in gray. Patients with obstruction exhibit worse overall survival, both secondary to sudden death and HCM-related death, defined as death secondary to heart failure, stroke, thromboembolism, or MI. In patients with obstruction, the objective of clinical management is palliation and control of heart failure symptoms. Although there is little evidence that currently available drugs reliably prevent disease progression over the long term, negative inotropic drugs in the form of beta blockers, verapamil, and disopyramide represent the traditional medical therapy that can be titrated to heart failure symptoms. Beta blockers are usually the first-line option, with verapamil or disopyramide added if symptoms persist. Medications can often provide some relief over the short term, but if patients' symptoms continue to progress, they can be managed with invasive procedures such as surgical myectomy or alcohol septal ablation to effectively reduce the size and contractility of the septum, the overall goal of relieving the obstruction. As you can see here, the HCM guidelines give a class 1 recommendation for the 3 classes of medications that I mentioned listed here. It's important to note that the level of evidence is B, based on non-randomized trials, which I will touch on later. It is also a class 1 recommendation to perform invasive intervention at high volume centers for patients with disabling symptoms, and an impaired quality of life due to longstanding LVOt obstruction with a gradient more than 50 millimeters of mercury despite medical therapy. The level of evidence for surgical myectomy is B and is also based on non-randomized trials. And alcohol septoablation is recommended for non-surgical candidates and is given a level of evidence C based on limited data. This prospective study looked at survival for patients who underwent septal myectomy compared to non-obstructive patients and patients with obstruction that did not undergo surgery. As you can see here, overall survival for those patients who underwent myectomy is comparable to the non-obstructive group up here, while the non-operated obstructed patients fared the worst. This data suggests that reducing the obstruction is associated with improved mortality, but there's never been a randomized controlled trial to definitively evaluate this question. Although medical therapy for LV outflow tract obstruction can result in variable degrees of symptom relief, we haven't seen any new effective drugs for the last 30 years, and the current medications available do not target the underlying mechanisms of HCM. There's little evidence that they fundamentally alter the natural history of HCM over the long term or are responsible for left ventricular remodeling. Also, none of the current standard of care therapies underwent evaluation by a large contemporary randomized controlled trial. There was a small randomized controlled trial with only 29 patients published recently in December of 2021 from a group in Denmark that was the first to show that metoprolol can reduce LVOT gradients compared to placebo. But this actually goes against the traditional teaching that beta blockers do not reduce obstruction, as prior trials failed to show any effect of beta blockers on LVOT gradients. It's also important to note that there are limitations to surgical myectomy and alcohol septoablation. Their inherently invasive nature means that not all patients will be candidates. There is a high risk for complications with these procedures, including heart block, infection, bleeding, damage to the aortic valve, and thromboembolism, as well as the potential need for repeat procedures after incomplete relief of obstruction, especially in the case of alcohol septoablation. These procedures require access to high volume centers, which poses a problem to those in rural areas or those in low-income countries without high quality medical care. For all of these reasons, developing a safe, effective, and disease-specific non-invasive therapy for obstructive hypertrophic cardiomyopathy is an important unmet need. So, to potentially fill this need, we have this new class of medications called the cardiac myosin inhibitors. First, let's talk about the normal actin-myosin interaction. Cardiac muscle contraction is powered by the ATP-dependent interaction of myosin with actin. Myosin is the major component of the thick filament seen here and can be divided into the head and tail domains. This animation, which I hope will play for you guys, depicts the typical cycle of cardiac muscle contraction, calcium binding there to troponin, which causes movement of the tropomyosin to expose the actin, allow binding of the myosin heads. The myosin heads then use the energy from ATP to move along the actin, creating a contraction. Here is another image depicting the ATP-dependent step. So ATP comes in here, binding to the myosin head, then undergoes hydrolysis into ADP and a phosphate molecule to allow cross-bridge formation. Phosphate is released and the myosin power stroke occurs. Then ADP is released and another ATP binds, allowing for the cycle to continue again. In 2016, researchers at Myocardia, a biopharmaceutical company in San Francisco, released a paper on a small molecule inhibitor testing it on cardiac myosin in mice. The molecule was labeled MYK461 with the chemical structure shown here on the left. They found that MYK461 inhibits myosin ATPase at a dose-dependent manner, seen here on this curve. Going back to our diagram of the actin-myosin cycle, This molecule is inhibiting the ATP hydrolysis step here that leads to activation of the myosin head. MYK461 has since been renamed to mavacamten, so I'll refer to it as mavacamten. So in this study, the researchers treated cardiac muscle fibers from rats to increasing concentrations of mavacamten. These first two bar graphs here show decreasing maximal tension and decreasing fractional shortening of the cardiac fibers with higher concentrations of mavacamten. They then administered mavacamten orally to young wild-type mice and to mice models of HCM expressing two different myosin heavy chain missense mutations. They measured left ventricular wall thickness by echocardiogram and showed that untreated mutated mice developed LV hypertrophy as expected, seen here in red. Mutated mice that were treated with mavacamten showed near normal LV wall thickness depicted in blue, and both treated and untreated wild-type mice, seen in the solid and dashed black lines, showed normal LV wall thickness. On histopathology, the untreated mice with HCM showed increased patchy fibrosis, seen here in the lower left, as these areas staining blue. The total area of fibrosis was between 4 and 10%, depicted in the bar graph here on the right in red. These R numbers correspond to the two different strains of HCM mice. The mice treated with mavacamten had about 80% less fibrosis, depicted in blue here on the bar graph, with almost no fibrosis seen on histopathology. The level of fibrosis in wild-type mice is depicted in black here. Essentially, when the mice were treated at a young age before the development of the HCM phenotype, mavacamten seemed to prevent the onset of hypertrophy and fibrosis. Another study looked at myosin conformational models. Myosin has two forms: in open active state, seen here, and a closed folded back state that does not interact with actin. This study combined mavacamten with purified myosin and looked at the conformational states of myosin under an electron microscope. These electron micrographs show examples of the closed state up here and open state along the bottom. The researchers counted the number of molecules in each state, both in the presence and absence of mavacamten. As you can see in the bar graph, the number of molecules in the folded state is much higher in the presence of mavacamten. This suggests that in addition to blocking ATP hydrolysis, mavacamten stabilizes this folded back state of myosin, making it less available for cross-bridge formation. Here's a cartoon depicting the mechanism of action of mavacamten that has been discovered thus far and how it applies to patients with hypertrophic cardiomyopathy. HCM-associated sarcomere mutations are thought to result in an excessive number of actin-myosin cross-bridges, leading to hypercontractility and hypertrophy. These pathophysiologic changes are effectively countered by mavacamten, reducing the number of cross bridges and/or reducing the contraction of the existing myosin heads to more closely resemble that of a normal sarcomere here. Let's now turn to some of the clinical trials that have been published on mavacamten therapy. Explorer HCM was published in 2020 in The Lancet. This was a phase 3 randomized double-blind placebo-controlled trial in 68 centers from 13 countries. We were actually one of the participating centers here at UW. This became the first large randomized controlled trial for a therapy to treat hypertrophic cardiomyopathy. A total of 251 patients were enrolled. Patients were randomized to mavacamten or placebo and followed over 30 weeks. They received mavacamten dose adjustments to maintain a plasma concentration between 350 and 700 nanograms per milliliter. Importantly, patients received serial echoes at each study visit to monitor ejection fraction. One of the main concerns is that the supertherapeutic doses of mavacamten may reduce contractility so much that patients develop significant systolic dysfunction and a reduction in EF. If at any time a patient exhibited an EF less than 50% on echo, there were specific protocols in place for temporary discontinuation of the study drug. The inclusion and exclusion criteria were primarily developed to prioritize safety and include a patient population adequately representative of real-world symptomatic obstructive HCM. Eligible patients were aged at least 18 years with a diagnosis of obstructive HCM, which was defined as unexplained left ventricular hypertrophy with maximal left ventricular wall thickness of more than 15 millimeters or more than 13 millimeters if the patient had confirmed familial hypertrophic cardiomyopathy. Patients had to have a peak LVOt gradient at least 50 millimeters of mercury at rest or after Valsalva maneuver or post-exercise. A left ventricular ejection fraction had to be at least 55%, and NYHA, the patients had to exhibit NYHA class 2 or 3 symptoms. Key exclusion criteria are listed here, which mainly involved recent history of arrhythmias. Of note, patients were allowed to continue standard HCM medical therapy, except disopyramide, as there is a cytochrome interaction between mavacamten and disopyramide. The primary endpoints of the study included an increase of at least 1.5 milliliters per kilogram per minute in peak VO2 measured by cardiopulmonary exercise testing, in addition to a reduction of more than 1 NYHA functional class, or an increase of at least 3 or more in peak VO2 with no change in NYHA functional class. Some could argue that these are soft endpoints and do not reflect hard outcomes that we are used to in large trials, cardiology trials. I will discuss why they chose these specific measurements in the next couple slides. Secondary endpoints included measured changes in the following: the post-exercise LVOT gradient, overall change in peak VO2 as measured by cardiopulmonary exercise testing, proportion of patients with improvement of NYHA class, and 2 questionnaires evaluating patient-reported outcomes, the Kansas City Cardiomyopathy Questionnaire and the Hypertrophic Cardiomyopathy Symptom Questionnaire. So the authors provide the following rationale for their choice of primary endpoint. This is data presented by the HCM group at Tufts, who followed 1,000 patients longitudinally. Overall rates of mortality and other adverse outcomes, including stroke, transplantation, and hospitalization, are low in patients with HCM with contemporary therapies, as you can see here. It's basically comparable to the general US population. Of course, this included low-risk asymptomatic patients with non-obstructive HCM, so it's not necessarily truly representative of the Explorer HCM study population. Nevertheless, the authors concluded it is not feasible to power this relatively short randomized trial of only 30 weeks to identify benefit for these hard clinical endpoints. So the primary goal of Explorer HCM was to test whether mavacamten can improve symptom burden and functional capacity, both important endpoints for patients and for providers. As I mentioned, the authors assessed functional capacity with 2 independent indicators, peak VO2 and NYHA functional class. They chose peak VO2 because it is a validated, direct, objective, and reproducible measure of functional capacity, and it carries some prognostic relevance. Peak VO2 reflects the maximal ability of a person to take in, transport, and use oxygen. It is measured directly during cardiopulmonary exercise testing, or it can be calculated using maximum heart rate, stroke volume, and net oxygen extraction from the peripheral tissues obtained during maximal exercise. Previously published studies in HCM have established minimally important change thresholds for peak VO2. An increase of 1 milliliter per kilogram per minute was shown to represent a clinically relevant threshold of improvement in HCM associated with a 21% reduced risk of all-cause mortality or cardiac transplantation. Another study looked at the prognostic value of peak VO2 in patients with HCM and found that having a peak VO2 below the median, seen here in blue, was associated with a higher risk of death, appropriate ICD discharge, stroke, or heart failure admission. At the end of treatment, 37% of patients on mavacamten met the primary endpoint, compared with 17% on placebo, with a statistically significant difference of 19.4%. Furthermore, 20% of patients on mavacamten had both at least a 3 milliliter per kilogram per minute increase in peak VO2 and improvement in NYHA class versus only 8% on placebo, with a difference of 12.5%. Mavacamten treatment was also associated with a significant improvement in all secondary endpoints compared with placebo, with patients showing reduced LVOT gradient, increased peak VO2, and improved symptoms as assessed by physicians with NYHA class or by the patients themselves as patient-reported outcomes in the questionnaires. In this first graph in the upper left, we can see that peak post-exercise LVOT gradient decreased from 86 at baseline to 38 at week 30 with mavacamten here in blue, whereas for placebo, the change was from 84 to 73 millimeters of mercury. This was a greater mean reduction by nearly 36 millimeters with mavacamten. In contrast to the decline in LVOT gradients, changes in baseline systolic function in patients treated with mavacamten were small, as seen here. The mean reduction was about 4% or so. Patients given mavacamten showed rapid and sustained improvement in resting and Valsalva LVOT gradients compared with placebo, seen here in the bottom two lines, mavacamten in blue, placebo in red. And it's important to note that a complete response, which the authors defined as a reduction in all LVOT gradients to less than 30 and reaching NYHA class 1, was met by 27% of the patients on mavacamten versus just one patient on placebo. Here's a bar graph showing the change in NYHA class between groups. All patients started in class 2 or 3. The proportion of patients who reached NYHA class 1 by week 30 was 50% with mavacamten and 21% with placebo. The study also measured serum NT-proBNP and troponin levels at various visits. There was a similarly rapid and sustained decrease in cardiac biomarkers parallel to the hemodynamic changes observed. At week 30 compared to baseline, the reduction in NT-proBNP seen here in blue for the mavacamten group was 80% greater than for placebo. And the reduction in high sensitivity troponin was 41% greater for mavacamten than for placebo, seen here. Just a little side note about biomarkers and hypertrophic cardiomyopathy. A study in 2011 followed 167 patients with HCM over 5 years and found that patients with troponin levels greater than or equal to 0.04, seen here in the upper left, and patients with BNP levels more than 200 had more frequent cardiovascular events compared to groups with low measures of troponin and BNP. When groups were allocated according to both troponin and BNP measurements, serum troponin used in conjunction with BNP, seen here, further improved the prognostic value. Patients with both troponin and high BNP values had an 11.7-fold increased risk of cardiovascular events compared with those with low troponin and low BNP values. So this data would suggest that troponin and BNP can be useful for parameters for identifying HCM patients at risk for adverse cardiovascular events. When it comes to safety endpoints, it is important to note overall 9 patients had a transient decrease in EF to less than 50% during the study, 7 in the mavacamten group and 2 in the placebo group. 5 of those patients, 3 on mavacamten, 2 on placebo, had protocol-driven temporary treatment discontinuation. After discontinuing the treatment for a brief period of time, EF normalized in all patients, and these patients resumed treatment and eventually completed the study. None of the patients developed signs or symptoms of heart failure. 4 additional patients on mavacamten had an EF less than 50% at the final study visit in week 30. EF was confirmed to recover to baseline after the 8-week washout period in 3 patients, while the 4th patient had a severe drop in his EF related to a procedural complication following AFib ablation during the washout period and only had a partial recovery to 50%. There were no significant differences seen during treatment between groups in the number of patients with any atrial fibrillation detected. There were also similar numbers of patients with episodes of non-sustained ventricular tachycardia in each group. However, the summary of episodes per patient at each time point showed that there were 1.5 to 2 times more episodes in patients with placebo compared to those with mavacamten. Here's a table that I recreated with slight modifications from a presentation by Dr. Ahmed Masri at OHSU. He made a compilation of studies that measured change in peak VO2 for patients with HCM. The overall peak VO2 increase for patients in the mavacamten group was 1.4 in Explorer HCM. We can see something interesting when we separate the patients who are on beta blockers from those who are not on beta blockers. Since beta blockers lower heart rate, they have an attenuating effect on peak VO2. For the patients on beta blockers, the change was only 1.1, but for those not on beta blockers, it was double at 2.2. Pioneer HCM was the phase 2 trial for mavacamten, which showed a significant increase in peak VO2 of 3.5 in patients not on beta blockers, albeit there were only 10 patients in that group. In this randomized controlled trial here from 2017, looking at the effect of moderate exercise on overall functional capacity, they found that exercise increased peak VO2 by nearly the same amount as mavacamten. It is important to note that only 17% of the patients in this study had obstructive HCM, while in the other studies listed here, all the patients had the obstructive form of the disease. This obviously makes it more difficult to make a direct comparison. When looking at changes after invasive intervention, we see a substantial increase in peak VO2 of 6.7 in 24 patients undergoing myectomy, and an increase of around 3 to 4 in patients undergoing alcohol septal ablation. The effect we are seeing with mavacamten is not as powerful as what we have seen with invasive intervention, which is something to keep in mind. A sub-study of Explorer HCM was performed examining the effect of mavacamten versus placebo on cardiac structure and function as assessed by cardiac MRI. 35 patients from the original study were randomized, 17 in the mavacamten group and 18 in the placebo group. What they found was that patients receiving mavacamten experienced a greater reduction in mean LV mass index from baseline to week 30, seen here, with a between group difference of nearly 16 grams per meter squared. Mavacamten was also associated with a greater reduction in max LV wall thickness, LA volume index, and mean ejection fraction, although the between group difference was only 6% for EF, and no patients from this sub-study had an EF less than 50%. Of note, when measuring late gadolinium enhancement, which is a marker of fibrosis, there was only a small amount of fibrosis in both groups at baseline, and there were no significant changes within or between groups. Coinciding with the Explorer HCM trial, there was a multi-center, double-blind, placebo-controlled phase 2 trial looking at the effect of mavacamten on patients with non-obstructive disease titled Maverick HCM. The hypothesis is that in addition to relieving obstructive physiology by decreasing contractility, mavacamten may also improve the abnormal relaxation and impaired myocardial energetics associated with HCM that are presumed to drive symptoms in the non-obstructive patients. For the sake of time, I will only briefly go through the results, given that this was a phase 2 study with a low sample size. They enrolled 59 patients. The authors used the same primary endpoint as the Explorer HCM trial, a change in peak VO2 and a change in NYHA class with the same thresholds, 1.5 and 3, and found that the number of patients achieving the endpoint was the same between the mavacamten and placebo groups. They also found that there were no significant changes identified in echo diastolic parameters across treatment groups, and no significant improvement in symptoms as assessed by the Kansas City Cardiomyopathy Questionnaire. However, the authors were able to show a reduction in cardiac biomarkers in the treatment groups compared to placebo. Mean NT-proBNP levels decreased by 40% in the low-dose mavacamten group in blue, and by 58% in the high-dose group, seen here in red. Keep in mind that this here is a log scale on the y-axis, so the actual decrease is larger than it appears on the graph. In the placebo group, there was only a 1% decline in BNP, this dashed line here. In participants with an elevated baseline troponin level, there was a statistically significant 34% decrease in the level at weeks 12 to 16 in the pooled mavacamten group, with no change in the placebo group. As you can see, then after drug discontinuation here, week 16, both BMP levels and troponin levels increased back to baseline. So to summarize these results, we have in this first randomized controlled trial for a cardiac myosin inhibitor that mavacamten treatment was effective in reducing LVOT gradients, improving symptoms, exercise performance, and overall health status. A little over 1/3 of the patients met the primary endpoint using both objective and subjective assessments of functional capacity. In truth, this can be interpreted in two different ways. Some of the prominent skeptics suggest that 1/3 of patients really isn't all that much. However, the absolute difference of 19% over placebo would calculate to a number needed to treat of 5 to achieve this improved functional capacity. So it may be somewhat meaningful. When it comes to safety, 6% of patients on mavacamten developed a reduction in EF to less than 50%, which normalized after temporary interruption or during the washout period in all patients except for one. None of the patients developed heart failure symptoms with a reduction in EF, except for the one patient who experienced the procedural complication after AFib ablation. The risk of causing systolic dysfunction is certainly something to keep in mind for future trials going forward, as I'll mention in the next slide. The MRI substudy did show a reduction in LV mass index and maximum LV wall thickness, as seen in the initial study with the mouse model of HCM. Whether this relates to the reduction in contractility is only speculative at this point. Mavacamten leads to a reduction in cardiac biomarkers in patients with obstructive and in patients with non-obstructive HCM. It remains to be seen if this leads to improved outcomes because these are truly just surrogate markers, but as we saw, elevated biomarkers do carry some prognostic value. The lack of functional benefit of mavacamten for patients with non-obstructive HCM could suggest that relief of obstruction is the primary therapeutic effect of mavacamten, but this will need to be evaluated further in the phase 3 follow-on study for these non-obstructive patients. The authors admit that the phase 2 study was underpowered to detect true differences in these functional outcomes due to the small sample size. In my opinion, I think we can be hopeful that these results can translate to better outcomes for HCM patients, but we should really temper our expectations. The increase in peak VO2 of 1.4, while significant, is much smaller than what we have seen with myectomy, in which the increase was 6 milliliters per kilogram per minute. Conversely, in the real world, patients in clinic could be put on higher doses of mavacamten than those in the trial to further reduce LVOT gradients, as long as there is no drop in their EF. Their dose could be pushed further, and this has the potential for providing more benefit than the signal in this trial suggests. There are several ongoing trials for which we are awaiting results. MAVA-LTE is the long-term safety extension study for patients who have completed Explorer HCM or Maverick HCM. Patients who were enrolled were put back on mavacamten or placebo after the washout period. The overall goal is to follow up long-term effects of mavacamten over 5 years, focusing on safety outcomes such as the development of systolic dysfunction. VALOR HCM is a randomized phase 3 double-blind placebo-controlled trial in patients who meet guideline criteria of eligibility for invasive septal reduction therapy. Patients are being randomized to mavacamten or placebo, and then they're followed for 16 weeks, after which they will tally up the number of patients who underwent SRT or remain guideline eligible for SRT. The overall goal is to determine if a 16-week course of mavacamten significantly reduces or obviates the need for invasive therapy. So those should be interesting results. One intriguing finding from the mice studies was the reduction in fibrosis and LV wall thickness when mavacamten was given before the onset of hypertrophy. There are many gene-positive patients who do not start exhibiting the classic phenotype for HCM until adulthood. One theory is that hypercontractility is the initial pathologic insult, and intervening to reduce contractility may reduce the level of disease overall. There is a possibility that these gene-positive patients could be started on mavacamten to counteract the hypercontractility before they develop hypertrophy and maybe delay or prevent the onset of disease. That, of course, remains to be seen. And finally, aficamten is another recently developed small molecule cardiac myosin inhibitor that is currently being studied in a phase 2 trial called Redwood HCM. Initial phase 1 studies showed a shorter half-life for aficamten compared to mavacamten, which some postulate will be advantageous in regard to more rapid titration as well as reversibility. So in October of 2020, soon after the publication of Explorer HCM, Bristol Myers Squibb acquired Myocardia, the manufacturer of mavacamten, for $13 billion. A new drug application was submitted to the FDA in early 2021, and mavacamten was actually initially slated to be available for prescription on January 28th, 2022, which everyone was excited about. However, in November, the review of the new drug application was extended to April 28th of this year. The FDA wanted sufficient time to review updates to the proposed risk evaluation mitigation strategy. Basically, this involves making sure there is an adequate database for tracking patients for safety outcomes, such as those with a drop in their EF. So in summary, mavacamten is a first-in-class small molecule selective inhibitor of cardiac myosin ATPase, specifically developed to target the underlying pathophysiology of hypertrophic cardiomyopathy by reducing active myosin cross-bridge formation with the overall goal of reducing hypercontractility. As of now, it has a promising niche in that it can be given to patients with symptomatic obstructive HCM who prefer to delay intervention or are not candidates for surgery. I work with Dr. Owens in clinic, as he mentioned, and we have several patients in whom we are waiting patiently to start mavacamten to help with their symptoms, since they either did not tolerate the other meds or do not wish to undergo surgery. Future studies will help us to determine the long-term safety of the medication and will hopefully give us more insight into clinically meaningful outcomes, such as potential mortality benefit. I want to take this moment to say thank you to everyone for giving me this opportunity to speak to you all. It has been a pleasure getting to know and work with everyone at the University of Washington. Even though my family and I are heading back to Minnesota after fellowship, I know that we will always have a home here in Seattle. And I will open it up now to any questions or comments.
Thank you, Rob. That was a great talk, great overview of the obstructive HCM and some of the potential new treatment strategies. There's a few questions. By all means, please, if you guys have any questions, put them into the Q&A section. I'll go ahead and read a couple that are listed here. Chinoso asks, what is the mechanism by which HCM enhances stroke risk?
I think there's probably several theories involved with that. And Dr. Owens is definitely much more of an expert than me. One of them being because of the elevated left ventricular diastolic pressures that then increases the left atrial pressures. You get increased fibrosis within the left atrium. And as we know from Dr. Akum's studies, increased fibrosis increases the risk of stroke with or without AFib. So the combination of left atrial fibrosis and atrial fibrillation certainly enhances stroke risk.
Great. And I think there's also, at least the subphenotype of the apical aneurysm adds an extra potential source of thromboembolism. Jeff Probstfield asks, I think you touched on this a little bit, are there any future trials planned? And were there any other adverse effects reported?
Yes, and so we did briefly touch on the future trials. I can just go back to that slide here. Somewhere, there it is. These are the future trials that are in the works right now, but I think there are certainly plenty more that I didn't dive into. As far as other adverse effects reported, There were several, in both the placebo and mavacamten groups, there were several mild to moderate adverse events that I think were reflective of patients with hypertrophic cardiomyopathy. There was no difference between groups. As I said, the incidence of arrhythmias was no different between groups. So all in all, mavacamten was a fairly well-tolerated drug. As I mentioned, more of the patients in the mavacamten group did develop the systolic dysfunction, but even that systolic dysfunction was well tolerated and the study drug was discontinued.
Great. I will, you mentioned here the slide here that I'll just point out that the MAVA-LT is ongoing. Valor HCM is currently recruiting. And then aficamten is there's the Redwood HCM trial we will be participating in. That'll be a phase 3 trial similar to the Explorer trial. There's a couple of other trials that are being developed right now. They've reached out to us to potentially be sites for them. And that includes a phase 3 trial for non-obstructive HCM as well. Great. Fareed has a question for you. Do you think that myosin inhibitors can work on thin filament hypertrophic cardiomyopathy? That is the genetic variation in the actin tropomyosin type of complex?
That's a great question. I know Fareed is much more of an expert in that sort of thing than me. I don't know the answer to that, to be honest, because mavacamten is really a drug affecting myosin heads and the thick filament. I certainly think there could be studies in the future to look at thin filament gene variants as well.
Yeah, great. In as much as hypercontractility is a key feature of hypertrophic cardiomyopathy, I think the mechanism of the medication it can benefit really any hypercontractility, no matter what sort of the genetic cause is. We did have some patients with thin filament HCM participate in the Maverick trial here, and they had a considerable symptomatic improvement. So even though the trial itself was negative for symptomatic improvement, now take a step back, that was a phase 2 trial designed for safety, not for outcomes. That at least there's some N of 1 that suggests that it can be beneficial for non-obstructive HCM as well. Great. And then Mel Thompson asks, does this medication have a role in ischemic heart disease by reducing myocardial oxygen demand?
That's a great question. It's certainly probably a theory. I don't think anybody has looked at that. And really in the studies that have been published so far, there hasn't been much of an emphasis on determining effects on chest pain. So I don't know the answer to that question.
Okay. And then Yoni Buber asks, for the increase in the peak VO2 in Explorer, is it possible that the drug caused a decrease in the stroke volume with a resultant increase in the heart rate, thereby elevating VO2 just as a result of that?
That is another excellent question. I don't think that there was actually a change in peak heart rates. I do remember the Explorer HCM trial looking at that. And the VE/VCO2 slopes showed improvement in the mavacamten group compared to placebo. So they tried to eliminate the heart rate aspect of the CPET measurements. And so they were trying to determine whether this beta blocker effect was, changing the peak VO2 final measurement, which indeed it was. But I think it's promising to look at those other types of measurements that don't include peak heart rate. There was an improvement in the mavacamten group. Sorry, that was a long answer, but I think it's not just a resultant increase in the heart rate.
Great. I think that's probably true. I think that we're done with most of the questions in the Q&A. Rob, I was going to have you put your a little bit of a speculative hat on, and I'm going to ask you this: the medicine, these myosin modulators are probably the best medicine we have for reducing contractility of the heart thus far. Disopyramide is the other medicine that may rival it, but I think this is stronger. And is going to raise some questions about safety and safety monitoring, and that's, I think, the biggest reason why the FDA approval was delayed. But I want to ask you, when we look at the Explorer HCM trial, only about a third of the patients, had met primary endpoint criteria. And what do you think the features are that prevents the other 2/3 of patients getting maximal benefit from this?
That's an excellent question. In my mind, I'm thinking that a lot of the patients who didn't receive benefit have worse heart failure with preserved ejection fraction. So their specific physiology, they have the higher left ventricular and diastolic pressures. And as we saw in the non-obstructive patients, there really wasn't any functional benefit. So and all of those patients, have this sort of heart failure with preserved ejection fraction phenotype. So I think that with or without obstruction, patients, there's an element of patients that also have HFpEF, and those patients probably don't show as much functional improvement with mavacamten.
Yeah, that might be. Now, and that leads to, I think, my second question, which was, there was a biomarker improvement in the patients with non-obstructive HCM. They speculate a lot of the improvement in the Explorer trial was due to reduction in the gradient. For the non-obstructive HCM, what do you think is the mechanism of benefit, or why do you think those folks showed a 50% reduction in the BNP levels and improvement in their troponin levels?
Yeah, that's a great question. I was trying to tease that out as well. There wasn't any functional benefit, but we were seeing the decrease in the biomarkers. It could be that the mavacamten is reducing stretch of the cardiac myocytes. In patients with the thick heart muscle, the increased contractility probably is causing some stress on the myocytes themselves. So giving mavacamten and reducing some of that contractility will reduce some wall stress. Maybe in these patients, it just wasn't enough to improve symptoms, but we were able to measure definitive biomarkers, or a definitive reduction in biomarkers.
Great. I just got a note here that said there was a question in the chat as well, and I wanted to bring that up. And that Nana was asking a question: is there a reason to believe that mavacamten would be beneficial for certain mutations and not others?
Yes, definitely. That is one of the questions that many investigators want to answer, whether treating patients with gene positive versus gene negative patients makes a difference. And so I think future studies will certainly look to see if different mutations respond differently to mavacamten. I think that'd be very interesting.
Yeah, I agree. Great. And then, Rob, I want you to just put one last question out there for you, and that is, where do you see, several years from now, mavacamten's approved, we're using it in clinical practice. Where do you see it fitting into the therapies available to patients with HCM?
So as of right now in clinic, I see it as really almost a fourth-line medication, although some could argue that mavacamten could be given before disopyramide. I think the safety of beta blockers and verapamil is well established, and so I personally would feel more comfortable starting with these first-line medications. And if patients continue to exhibit symptoms, considering mavacamten as opposed to starting disopyramide. Disopyramide does require more constant monitoring of QT interval and things like that. Also, as I mentioned, really in those patients who are wary of invasive intervention, they don't want to go through a cardiac surgery, but they also just want to feel better. I think they are perfect candidates for a trial of mavacamten to see if they can experience some relief.
Yeah, I agree with that. I think that there are limitations to the idea that reduction in contractility is going to completely affect the obstruction, and there's a lot of anatomic features that play a role in that obstruction that the mavacamten and other medications cannot overcome. Sort of my experience, but I'll just make one general comment at the end, and take a step back and look at this as a huge success for the HCM field. This is really the first positive randomized controlled trial within the field of hypertrophic cardiomyopathy that's been studied now for close to 60 years. So we've been really looking forward to having new medications and new options for this patient population. And the idea that we might be able to target hypercontractility, the hypercontractility can be in and of itself a target for therapy, is a very intriguing one. And how that might affect patient outcomes, both obstructive and non-obstructive, and maybe even for those patients who carry gene mutation but haven't yet developed hypertrophy, whether or not we can prevent the development of the disease to begin with. That's all speculative. Those are things that still need to be worked out. But we finally have a medication that allows us to ask some of those questions and hypothesize what these types of therapies might provide. Rob, that was a great talk. I appreciate your efforts in clinic. I appreciate going over everything today. Yeah, thank you everyone for joining in.
All right, thank you so much.